This is Dr. Jacob Baranowski, and this is the lecture associated with the endovascular approaches to narrow-necked intracranial aneurysms chapter. The objectives for this lecture are as followed. We will review the endovascular treatment options for narrow-necked cerebral aneurysms. We will discuss the clinical decision-making when deciding whether to treat a narrow-necked aneurysm via either endovascular or open surgical techniques. And we will review an operative video highlighting the techniques and principles of primary coiling for a narrow-necked aneurysm. As a point of introduction, narrow-necked aneurysms are those aneurysms with a neck diameter of less than 4 millimeters or a dome-to-neck ratio of less than 2. Although these definitions differ slightly throughout the literature. When deciding when and how to treat any aneurysm, it is important to take an individualized, patient-specific approach. This should factor in the clinical presentation, the natural history of the aneurysm, the location and morphology of the aneurysm, the morbidity associated with the various treatment options, and the surgeon ability and comfort to treat the lesion. Overall, narrow-necked cerebral aneurysms are well suited for endovascular interventions. With a continuous evolution of endovascular technology and techniques has led to an expanded armamentarium for the endovascular neurosurgeon and has allowed for a greater number and types of aneurysms to be treated by endovascular therapy with a greater degree of safety and efficacy. Again, the exact treatment technique selected should be based on the individual characteristics of the patient and the aneurysm in question. While these techniques have advanced, the hallmark procedure in any endovascular neurosurgeon's armamentarium is the primary coil embolization. While an exhaustive discussion of the complicated decision-making process regarding which aneurysm should be treated and via which technique is beyond the scope of this chapter, we will offer a framework to assist with deciding whether a narrow-necked aneurysm is better suited for endovascular therapy or open microsurgical clipping once the decision has been made to proceed with aneurysm treatment. In general, given the recent advances in endovascular treatment technologies and techniques, and an overall success of these modalities in treating narrow-necked aneurysms, we advocate for an endovascular-first approach to any narrow-necked cerebral aneurysm, regardless of rupture status. However, there are certain factors that we would recommend considering prior to deciding upon your approach. Firstly, the presence of a large hematoma remains an absolute indication for open surgical treatment to allow for alleviation of the associated mass effect prior to treating the aneurysm. Secondly, one must consider the ability to successfully navigate a microcatheter to the aneurysm in question, and recall that if the lesion is in a small distal artery, it may not be possible to navigate the necessary catheters to an appropriate position to proceed with endovascular treatment. In these scenarios, the risk of proximal sacrifice of the vessel must be weighed, and if this is deemed unacceptably risky, open surgical treatment should be preferred. Thirdly, if the aneurysm parent vessel configuration is such that a stent may be necessary to keep the coils from protruding into the parent vessel, this should be considered a relative contraindication in the setting of aneurysm rupture due to the current need for dural antiplatelet therapy following stent deployment. A fourth consideration is whether there is an arterial branch coming off the dome or base of the aneurysm. In these cases, it may be difficult to sufficiently occlude the aneurysm endovascularly while preserving the patency of the branch artery, and therefore open microsurgical clipping may be the preferred method of treatment. Aside from these scenarios, and particularly if the aneurysm is in the posterior circulation, we would advocate for an endovascular first approach and recommend endovascular treatment for the majority of narrow-necked aneurysms. We will now work through this decision-making algorithm, starting with the ruptured side. If there is a clot, again, open surgical treatment is preferred to allow for evacuation of the hematoma and alleviation of mass effect, while simultaneously addressing the ruptured aneurysm. If there is no clot present on the initial CT scan, we would recommend proceeding with an angiogram to determine whether or not the aneurysm can be safely treated via endovascular therapy. If there is unfavorable branch anatomy, or if there is a concern that vessel sacrifice may be needed in order to adequately treat the aneurysm, or if there is concern that the aneurysm would need stent-assisted coiling, it is then appropriate to consider open surgical intervention. However, if the aneurysm has a favorable branch anatomy and is able to be treated via primary coiling without stent assistance, endovascular intervention should be undertaken. When planning treatment for an unruptured aneurysm, we would advocate for having an angiogram prior to proceeding with either endovascular or open microsurgical treatment. Based on the results of the angiogram, if it is deemed that the aneurysm has unfavorable branch anatomy, or if it's a distal aneurysm that may require parent vessel sacrifice, we would recommend considering open surgery to best treat these lesions. If the aneurysm has favorable branch anatomy and parent vessel sacrifice is not necessitated, then endovascular therapy should be undertaken. As this is in the unruptured setting, the need for stent-assisted coiling should not be considered a relative contraindication to proceeding with endovascular therapy. For narrow-necked cerebral aneurysms, primary coil embolization remains the endovascular treatment of choice. For difficult aneurysms, balloon remodeling can also be utilized to assist with primary coil embolization. When performing a primary coil embolization of an aneurysm, it is important to obtain excellent working angles and a thorough understanding of the aneurysm and parent vessel anatomy prior to proceeding with treatment. The nuances of treatment depends on aneurysm location and morphology. In general, the angiomorphology of a narrow-necked aneurysm makes it less likely for coil herniation to occur, thus making it less likely for adjunctive additional techniques to be needed. We will now review an illustrative case of primary coil embolization for a narrow-necked cerebral aneurysm. This is a case of a 60-year-old male who presented with aneurysmal subarachnoid hemorrhage with a Hunt-Hess grade of 2 and a modified Fisher score of 3. The preoperative CT angiogram demonstrated a right A1-2 aneurysm that appeared to be narrow-necked. Based on our treatment algorithm, the patient underwent a cerebral angiogram before considering treatment options. Treatment options for this case include open microsurgical clipping or endovascular treatment. The endovascular treatment would most likely consist of primary coil embolization, possibly with balloon remodeling, and possibly with stent-assisted coiling if necessary. Here we see the results of the cerebral angiogram demonstrating a narrow-necked A1-2 aneurysm whose angiomorphology appears overall favorable for primary coil embolization. Again, it is important to obtain excellent working angles prior to proceeding with endovascular treatment for these aneurysms. This is the operative video of the endovascular treatment via primary coil embolization for this ruptured A1-2 aneurysm. We can see the working angles projected on the right-hand side of the screen based on the 3D rotational spin, and we can see the narrow-necked aneurysm protruding from the A1-2 junction. Before undertaking primary coiling for these aneurysms, it is important to consider the placement of the microcatheter, whether or not you have adequate proximal support, and then to watch for the movement of the microcatheter during placement of the coils. Here we see the microguide wire tracking distal to the aneurysm and then tracking the microcatheter to the neck of the aneurysm. With the microcatheter sufficiently placed within the aneurysm, framing coils are placed, watching for microcatheter kickback or coil herniation into the parent vessel. Again, multiple control angiograms in between coil placements to ensure adequate and sufficient placement of the coil mass, but also watching for catheter kickback or coil herniation is crucial. After placement of the framing coil, additional coils are selected and deployed into the aneurysm in a stepwise fashion, again with multiple control angiograms in between coil placement to ensure adequate filling of the aneurysm with the coil mass, while also ensuring that there is no microcatheter or coil prolapse into the parent vessel. We can see with subsequent deployment of multiple coils, we get excellent filling of the aneurysm with the coil mass, and we see decreased filling of the aneurysm on subsequent angiographic runs. We know that coil packing density is an important factor in determining whether an aneurysm will remain occluded following endovascular treatment, and a coil packing density of greater than 25% is preferred. The final angiographic run demonstrates complete occlusion of the aneurysm with no residual filling while maintaining excellent parent vessel patency. Following the procedure, the patient tolerated the endovascular treatment well. On the right, we can see both the subtracted and unsubtracted views of the coil mass following treatment with an excellent coil packing density as well as complete occlusion of the aneurysm without any evidence of parent vessel occlusion or stenosis. Overall, the patient recovered well from his subarachnoid hemorrhage. His hospital course consisted of being able to be weaned from his external ventricular drain. He did not go on to develop any vasospasm and was able to be discharged after 14 days with a modified Rankin score of 1. In conclusion, endovascular treatment options continue to evolve. Overall, narrow-necked aneurysms remain well suited for endovascular intervention. As with any aneurysm, personalized intervention based on the individualized patient and aneurysm's characteristics is essential. Primary coil embolization remains the workhorse procedure for endovascular treatment and is the foundation on which more complicated treatments are based.